And there are the perivascular cells, also called C cells. In addition, capillaries are common to see, indicating the thyroid has an abundant blood supply. The function of the thyroid gland is to take iodine and convert it into thyroid hormones. Thyroxine is also called T4, and the triiodothyronine, also called T3. T4 and T3 are two important kinds of the thyroid hormones. These hormones help regulate your metabolism. They affect how fast your heart beats, how deep you breathe, and whether you gain or lose weight. They can also help control your body's temperature, cholesterol levels, and women's menstrual cycles. During the infancy or childhood, the thyroid hormone is very important for brain development. Thyroid diseases include the conditions associated with the excessive release of the thyroid hormones or the reduced levels of thyroid hormones and the mass lesions of the thyroid. Okay, so now we talk about the first disease, hypothyroidism. This disease is a clinical state caused by the struggle or the functional derangements. Or in rare cases, because of the resistance of the tissues to the effects of the thyroid hormones. According to the age at onset of this disorder, hypothyroidism is divided into two types or two forms, creatinism and myxedema. Creatinism is the development of severe hypothyroidism during infancy and childhood, while the myxedema is the adulthood hypothyroidism. So first, let's look at the causes of the creatinism. What are the causes? We know that thyroid hormones are produced by thyroid gland. So if there are developmental anomalies or developmental problems in the thyroid angiogenesis, the amount of the thyroid hormones will be surely reduced, right? Or the abnormal synthesis process of thyroid hormones is another cause of creatinism, which is often caused by genetic defect. Fetal exposure to the iodines and antithyroid drugs will also influence the production of thyroid hormones. A special cause is the lack of iodine in diet. Formerly, creatinism is fairly common in areas where the dietary iodine deficiency is endemic. But now it's much less frequent because of the supplementation of salt with iodine. The clinical manifestations usually become evident within a few weeks to months of birth. The child may present features like slow to thrive, poor feeding, constipation, the dry skin, the hoarse cry, and bradycardia. These other impaired skeletal growth and some problems in the central nervous system. The patient often has a round face, narrow forehead, widely set eyes, flat and broad nose, with big protuberant round tongue. Neurological features including the deafness, spasticity, and mental deficiency. Characteristic lab tests include a rise in TSH level and a fall in T3 and T4 levels. Hypothyroidism in older children and adults results in the myxedema. There are also several causes, but the first two are the most common causes: ablation of the thyroid by surgery or radiation, and autoimmune thyroiditis. The treatment of many thyroid conditions needs surgical removal of a portion or all of the thyroid gland. If the mass of thyroid left within the body is not enough to meet the needs of the body, the patient will develop hypothyroidism. Autoimmune thyroiditis is a form of thyroid inflammation. This disease is caused by the patient's own immune system. Because of the inflammation, a large percentage of the cells of the thyroid are damaged or dead and incapable of producing sufficient hormone. In rare cases, because of a problem in the pituitary gland, although patient has a completely normal thyroid gland, but it is not making enough hormone. The onset of myxedema is slow, and a fully developed clinical syndrome may appear after several years. The characteristic signs are cold intolerance, mental and physical lethargy, constipation, slowing of speech, puffiness of face, loss of hair, and altered texture of the skin. But each individual patient may have part symptoms, and they will vary with the severity of the disease. Laboratory diagnosis is also made by the low serum T3 and T4 and the markedly elevated TSH levels. But remember, there's a cause of the pituitary lesions. So in that case, the TSH levels is reduced. Okay, now please look at these two pictures and tell me who is cretinism patient and who is myxedema patient.
Ma'am, the left one is cretinism, the right one is myxedema.
Yes, right. Cretinism, a child, and myxedema, an adult, right? Okay, good. The second disease we talk is chronic lymphocytic thyroiditis. This is also called Hashimoto's thyroiditis. The disease is named after the Japanese surgeon who discovered it in 1912. It is also an autoimmune disorder. In this case, immune cells mistakenly attack the healthy thyroid tissue, causing inflammation of the thyroid. This disease is not only the most common type of the thyroiditis, but also the most common form of the primary hypothyroidism. The Hashimoto's thyroiditis is most prevalent between 45 to 65 years of age, and it affects women more than men. So the sequence of the immune phenomena is initial activation of the helper T cells. These cells then induce three proposed models of the thyroid cells destruction: CD4 positive T helper cells, infiltration of CD8 positive T cells, resulting in the T cell mediated cytotoxicity. B cells or plasma cells, which form the autoantibodies, causing the ADCC or antibody-dependent cell-mediated cytotoxicity. So, a kind of the autoimmune disease. What pathological changes that the Hashimoto's thyroiditis have? We look at the pictures. Grossly, the thyroid is usually enlarged diffusely and symmetrically. The capsule is often intact. Sectioned surface is pale or tannish yellow color, firm, and friable, with a lobulated appearance. Histologically, there is infiltration of the gland by lymphocytes, plasma cells, and macrophages, with formation of the lymphoid follicles. We call them geminocytes. There is a decreased number of thyroid follicles, which are generally atrophic and often devoid of colloid. The follicular epithelial cells are transformed into their degenerated state, termed Hustler cells. These cells have abundant eosinophilic, and granular cytoplasm. Less commonly, the thyroid is small and atrophic as the result of more extensive fibrosis. We look at this picture. This is a photo of Hashimoto's thyroiditis. Here we can see there is large infiltration of leukocytes, such as the plasma cells, macrophages, lymphocytes, but we can't tell exactly the cell types here. There is a geminocytes, residual thyroid follicles lined by deeply eosinophilic Hustler cells are also seen. We look at this picture, it's more clear. Here, large number of the infiltrated lymphocytes, and among them, there are Hustler cells. Here, these cells have the eosinophilic and granular cell plasm because of the large number of mitochondria and they contain large nuclei. Some follicles are atrophic. Okay, so Hashimoto's thyroiditis or chronic lymphocytic thyroiditis is commonly seen in middle-aged women. Patient often has a pallid, firm, and moderate enlargement of the thyroid gland. There is a gradual hypothyroidism, progressive or gradular hypothyroidism. The levels of the T3 and T4 in serum are both decreased, and the TSH is increased. In addition, patients with the Hashimoto's thyroiditis often have other autoimmune diseases. There is no increased risk for developing thyroid carcinoma. So it's a good message to these patients. But there is increased frequency of malignant lymphoma in these cases. Okay. Before we start the third disease, we have a 5-minute break.